Value-based care, the simple equation that will allow America to save more lives, improve quality, and decrease costs. What could go wrong? Welcome to PCP Lens. My name is Sudeep Bansal, and I'm a primary care physician. In this video, I will take you on a journey on how a simple, powerful idea called value-based care that was destined to solve America's healthcare problem instead caused a crisis in primary care by creating a high-stakes game of metrics and madness. Let's get started. Those who cannot remember the past are condemned to repeat it. So, we're going to start with a little bit of history. Bear with me. Let's start with patient-centered medical home. The concept of PCMH originated in the 1960s within pediatrics to care for very sick children who had very complex illnesses. Illnesses that needed a team of doctors or other medical professionals to help manage. The idea behind PCMH was simple. Have an adequate infrastructure such as buildings, equipment, and staff, and have good processes to care for people so that things don't get missed. PCMH was intended to be a model of care which organizations could take and build upon. The goal was that organizations would provide better care to people by improving processes, coordination, access to care, and decreasing medical errors. As far as I know, this was the first time a cohesive concept of quality in healthcare was articulated and adopted. PCMH does exist today, not just as a model of care to build upon, but as a certification for healthcare organizations to achieve. Now that we have a precursor to quality, we need a precursor to cost. Enter HMOs. HMOs were the invention of insurance companies as they needed a way to control healthcare costs. In fact, the prepaid health plans popular in the early 1900s, they were a precursor to HMOs. Over time, as the cost of medical care increased, insurances started experimenting with different types of HMO plans to try to figure out how to reduce cost. And they did that mainly by decreasing reimbursement to doctors and reducing insurance benefits by creating carve-outs. That is, what the plan will cover and what they will not cover. So for example, mental health, that was a popular carve-out and was not part of several medical insurance plans. Now, all of these different plans to choose from, people started getting really confused on what the insurance policy covers. The HMO Act of 1973 tried to curb some of these abuses, and eventually these plans started falling out of favor. And the reasons for decline in HMO popularity was predominantly due to insurances denying care to people and decreasing payments to doctors with the goal to reduce the cost of care or to make a profit. And here we are 20 years later with the exact same complaints about insurance companies. So the question is history repeating itself? So why learn from history when you can make money by repeating it? So yes, I do think history is repeating itself. And the powers to be have decreed that this time it's different because we have more data, so we won't make the same mistakes of the HMO era. But is this data going to be used to improve care, or is it going to make more profits? Let's dive in. In March 2001, the Institute of Medicine released an influential report called Crossing the Quality Chasm. This study grabbed national attention as it highlighted the vast gap in quality of care that Americans receive compared to the NHS in the United Kingdom. By the way, it is ironic that in America, we don't like the socialist UK health system, and yet UK outperforms us by keeping their population healthier. This report led to the rise of the pay-for-performance model, that is, incentives to improve quality. Essentially, health plans started giving out what they call bonuses to doctors and health organizations on top of the regular fee for service to meet quality thresholds. Most insurances just repackage the increase in regular fees that doctors would have received to account for inflation into bonuses. So, if there was a 2% inflation from 2005 to 2006, then instead of increasing the payment to doctors by 2%, doctors could earn a 1% bonus if they met the quality metric targets. Insurance companies, they always win. CMS, which runs Medicare, started experimenting with pay-for-performance in 2003 and officially launched the Patient Quality Reporting Initiative in 2007. Private insurance companies started putting quality metrics in their contracts with all providers. And the vast majority of these metrics, they were directed towards primary care. There was a time when primary care physicians were held responsible for more than 100 quality metrics. And if you're thinking, what's wrong with this approach? Doctors should provide high-quality care. Well, my friends, these quality metrics, they don't reflect quality at all. These metrics and targets, they're designed by insurance companies so they don't have to pay money out of doctors. But again, more on that later. Let's go back to where we left off. The end result of all these quality metrics? Frustrated doctors trying to prove that they're providing good quality care. And to do this, medical practices were spending approximately 15 hours per week per physician to collect and submit data to the insurance company. to the tune of $15.4 billion per year in our country. If doctors did not submit this data, they not only did not receive inflation adjustment payments, but they also took a pay cut. This money that was not paid out to doctors was kept by insurance companies or the large employers paying premium on behalf of the employees. Irrespective, corporate America kept its profits at the expense of smaller practices, which lost money year after year due to rising business costs and decreasing reimbursement. Many just gave up and joined larger practices or health systems. By the way, these larger practices and health systems, they survived. They hired an army of people to collect and report quality data to insurance companies. These large organizations, they did not provide better quality care as compared to smaller practices. They were just better able to report the data to the insurance companies. This had the unintended side effect of larger organizations becoming even larger by buying out these struggling small practices at bargain prices, which then gave them more negotiating power. And they used it to go back to the insurance companies every subsequent year, and they were able to negotiate higher payments. The sweet sound of consolidation and profits on Wall Street. By the way, if you're watching on YouTube, please like and subscribe. If you're watching on PCPLens.com, and if you have not subscribed, please consider becoming a paid subscriber. Getting back to our story, CMS realized they created a monster enforcing all these quality metrics on doctors, so they attempted to scale the number of quality metrics back in 2011 under a program called Patient Quality Reporting System, or PQRS. But they forced all the doctors to participate in the name of improving quality. For the powers to be, PQRS and pay-for-performance contracts, they somewhat solved the problem of quality. What about healthcare costs? After all, healthcare costs were still rising rapidly and something needed to be done. Enter Michael Porter's influential book in 2006, Redefining Healthcare. It took the complicated world of healthcare and neatly summarized it into a simple equation, which became known as the value equation. This value equation was defined as achieving better health outcomes for lower cost. Now, I've personally not read Michael Porter's book, but I have read his articles in Value-Based Care and in the New England Journal of Medicine. Based on my reading of these articles, my understanding is that outcomes, they're an attempt to measure if the person benefited from treatment. But first, to do that, you have to define the health condition. For example, back pain, and the expected benefits the person would receive. For example, pain-free days, absent days from work, use of painkillers, or emergency room or hospital visits. Cost refers to the total cost of the entire cycle of care for the patient's medical condition, not just the cost of individual services. So, for example, the total cost of care for back pain for an entire year instead of individual office visits. As you can imagine, it is hard to measure value in a single individual, as every individual is different. However, you can extend the framework of population health to measure value in a population. Now, I talked about population health in my last video, From Doctors to Social Workers. If you've not seen it, I would strongly encourage you to check it out now. Now, if you can define the value of a population, it can be bought and sold in a private marketplace. So here's how population health maps to value-based care. Under population health, we study why one population is healthier than others. In value-based care, this is extended to the study of why one population is more expensive to care for than others. Under population health, we attempt to identify which risk factors lead to poor health. In value-based care, we attempt to determine how much more expensive it is to take care of people with these risk factors. And lastly, in population health, the goal is to implement policies to mitigate and improve the health of the population. In value-based care, this changes to how can the medical system decrease the cost of care by mitigating risk factors by treating people. Now, I'm totally reverse engineering Michael Porter's work, but it is hard to miss the inspiration that population health has had on value-based care. The concept of value-based care was a masterstroke given its simplicity. However, organizing healthcare around the value equation was a bold and radical proposal, and implementing it proved challenging without any incentives. Enter Obamacare. The Patient Protection and Affordable Care Act, or what is popularly referred to as Obamacare, was passed in 2010. This was a sprawling legislation and had several great provisions. Remember not being able to get health insurance due to a pre-existing condition? Yeah, that was outlawed. But Obamacare also created several incentives to implement value-based care, and it did that by creating two different entities. The first one was called the Accountable Care Organization, which is a network of providers that agree to work together to improve the quality and reduce the cost of care. The next one was the Center for Medicare and Medicaid Services Innovation, or CMMI. This was the innovation arm of CMS that was tasked with experimenting with different payment models to find a model that would reduce the total cost of care without sacrificing quality. CMMI was funded with $10 billion every 10 years. Since its creation, CMMI has experimented with several value-based care models in an attempt to reduce healthcare costs. While I'm all for experimentation to get the rules right, from my viewpoint that is a primary care physician, this has been an unmitigated disaster by sowing confusion and increasing bureaucratic paperwork, or should I say electronic record data entry. The 2015 MACRA Act tried to take the lessons learned from CMMI and the pay-for-performance madness, which providers were still subject to, and they tried to simplify it. So they created two more programs. The first one was called the Merit-Based Incentive Payment System. This was the successor to pay-for-performance, and this was mandatory for providers to report quality metrics. Failing to report would lead to financial penalties in the form of lower payments. The next was alternative payment models. This was the financial implementation of a value-based care contract. Providers were still required to report quality metric performance, but now they were also accountable to the total cost of care. Now, before we look at the value-based care contract, let's look at the progression of the so-called payment reform in healthcare in the United States. The original payment system, fee-for-service, providers were paid a flat negotiated fee per visit. Next is the pay-for-performance. This was built on top of the fee-for-service model where doctors and health organizations received additional funds to prove that they're providing good quality care. Next was the upside risk-sharing value-based contract. You still had to report on quality metrics, but now the ACO was also responsible for the total cost of care. If the ACO saved money, then they get to keep a portion of those shared savings. If they spent more, at least they didn't have to pay anything back. Lastly, the downside risk-sharing value-based contract. Here, the ACO had to pay money back to the insurance company if they spent more than the allotted budget. Essentially, the ACO and all the doctors in it became a mini insurance company. So what does a value-based contract look like? So in order to measure value, we first need to define a population. And this is done by identifying all the PCPs in an ACO and their patient panel. That becomes the attributed population in which value will be measured. Next, we need to determine how much this population is expected to cost. That is, a budget. This is calculated by looking at pre-existing conditions and demographics, such as age. And then to avoid repeating the mistakes of the HMO era, where health plans and organizations were skimping on care to save costs, these contract measures outcomes, which essentially are performance on quality metrics. By the way, we will discuss patient attribution and budgets in the next couple of videos. In this video, I want to explain how quality is measured in these contracts to give you a taste of the money and madness involved in these contracts. To measure quality, CMS or the insurance companies assign quality metrics to provider organizations, which is mainly primary care. Hospitals also have quality metrics, but in this video, we're going to be talking about primary care, so I won't be discussing hospital quality metrics. Most of these metrics are developed by an organization called the NCQA, or National Committee for Quality Assurance, and these metrics are called the HEDIS measures. Examples include diabetes control, colon cancer screening, breast cancer screening, etc. Then there is a quality gate, that is the minimum threshold that providers need to meet in value-based care. If providers don't meet this threshold, they don't get a bonus, even if they reduce the total cost of care. Guess who keeps the money? Yes, this becomes a profit for the insurance plan. Talk about aligning incentives to improve quality. The insurance companies have every incentive to make the quality gate as hard to achieve as possible, and this is a subject of intense negotiations. And then there is the final target. Insurances, depending on the negotiation, might pay an additional bonus for improving quality beyond the quality gate till the provider reaches the final target. Let's take a look at an example to hopefully try to make this easier to understand. This table shows a sample of quality metrics that an ACO, and by extension a PCP, is responsible. Now I'm taking only a small sample of metrics to keep the table and the calculation simple. Next are the hypothetical quality gates that an ACO needs to meet. So for example, 80% of the patient should have their blood pressure under control for an ACO or the doctor to get a percentage of shared savings, which is the amount of money saved by reducing the total cost of care. Then we have a target percentage. Insurances, depending on the negotiation, may provide additional shared savings for improving quality after meeting the quality gate till the ACO hits the target. So for example, I may be eligible for more money from the insurance company if I improve the quality of blood pressure metric more than 80% till I hit 90%. Now, in addition to measuring each metric individually, the plans also measure aggregate quality gates and the aggregate target that the ACOs are required to meet. So now let's take a look at the performance of a fictional ACO. You can see that this ACO achieved 79% on the aggregate quality performance. So this ACO is eligible for shared savings as its performance is higher than the aggregate quality gate of 76%, which was set by the insurance company. In this hypothetical example, the insurance and the ACO negotiated that the ACO will receive 50% of shared savings. If the ACO saved $1 million, then the ACO will receive $500,000 in shared savings and the insurance company will keep the rest. Now, let's say the hypothetical ACO negotiated an additional 1% of shared savings for each percent increase in quality performance after meeting the quality gate till they hit the target. So in this example, since the ACO's performance was 79%, it may be eligible for an additional 3% of shared savings, which is 3 points above the quality gate. Therefore, in this case, the ACO will be eligible for 53% of shared savings. Confused by this complicated contract? So are a lot of primary care doctors. Now, let's make it even more complicated. In this last column, you can see that the ACO did not meet the quality gate for colon cancer screening. The value-based contract may have a poison pill. That is, if you don't meet the quality of one or more metrics, then the ACO does not get any shared savings. So some of the negotiation points in these complicated contracts revolve around the quality gate and the target percentage that ACO or the providers need to meet. How many quality metrics and gates need to be met to qualify for shared savings? What is the aggregate quality percentage gate? Is there a different weight given to different quality metrics depending on the importance? So for example, insurance companies might give more weight to colon cancer screening than measuring BMI. And then what percentage of shared savings will the ACO providers receive if they increase performance beyond the quality gate? Is your head spinning? Yeah, mine too was when I first learned about these. Most doctors are busy taking care of patients and they don't have the time to learn the intricacies of these contracts. Also, would you rather have your doctor in their free time staying up to date with medical literature than learning about these complicated contracts? Not only are these value-based contracts complicated, all the health plans in large organizations can game these parameters to increase their profit. For example, health plans can make the quality gates and targets unachievable so they don't have to pay money out to the ACOs or the doctors. Health plans and ACOs can make people look sicker so that they get a larger budget to make more money. And health plans can decrease costs by increasing the use of prior authorization and denying care. And that, my friends, is how you gamify and make a profit in value-based care without making people healthier. Since small practices are too busy taking care of patients, they don't have the resources to play these games. They either go bankrupt or join large organizations, which then reduces access to primary care. And there's plenty of data to show that when people don't have access to primary care, the health of the population gets worse. So much so for improving quality of care in these value-based care contracts. If there's one take-home point from this video, it is this. The burden of value-based care falls on primary care. These contracts, they create the illusion of improving care while reducing access to primary care. Thank you for watching this video. You can find a written version with references to the material that I discussed in this video on PCPLens.com. You will also find an audio podcast version of this video on PCPLens.com. If you're watching on YouTube, please like and subscribe. This helps me find a wider audience and spread the message. Now, throughout this video, I've dropped several hints about upcoming videos. The next video will be on patient attribution in value-based care. If you like this video, please sign up on PCPLens.com so that you don't miss the next episode on patient attribution when it's published. Thank you for watching. Take care and goodbye.